So, good evening to one and all. As part of World Leprosy Day program, we GAIMS presenting before you two different clinical presentation. Today, GAIMS is privileged to have Professor Dr. Rajeshwar Reddy Kasarla sir, Head of Department of Microbiology of Universal College of Medical Sciences, Bhairahava, as our mentor today. A very welcome to you, sir.
Thank you. Thank you. Thank you.
So, VGIMS presenting you two different clinical presentation of same disease. This is to make you little familiar with the disease. You all would have guessed it. The disease I am referring to, leprosy or Hansen's disease. This disease knows no boundaries. So to begin our case, sir, shall we proceed to our case presentation?
Yes, yes. Carry on.
So for our first patient was a 50-year-old female who complained of reddish raised skin lesion of cheeks and forehead, which were photosensitive in nature and of 1 year duration. She also had numbness of both feet. In left feet, it was more than its right feet. She had consulted physicians and many neurologists and was thoroughly investigated, but search for the diagnosis continued. So our examination revealed that there was erythematous plaques over malar areas, forehead, and erythematous infiltration of both external ears. Inverted saucer-shaped erythematous plaques asymmetrically on both stems were present. For nerves, there was left lateral popliteal nerve alone was thickened and patient had foot drop of left leg. She also had incomplete glove and stocking anesthesia. As we further investigated her, her skin biopsy was done elsewhere, so there was no repeated or any complication was found. We investigated, there was slit skin smear and it was found positive and confirmed our diagnosis of lepromatous spectrum of leprosy. Now moving on towards our case 2. There was 43-year-old young executive complained of insensitivity to cold as he could walk around without socks even when it snowed. He had past history of brief treated for tuberculosis, Hansen's disease for numbness, and weakness on his left hand and chance finding of hypopigmented macule of left elbow. This was 10 years ago, and he was diabetic and on treatment. In examination finding, there was its examination did not reveal any hypopigmented skin patches. He had multiple thickened peripheral nerves, including left lateral popliteal ulnar and left radial cutaneous nerve of forearm, and also right ulnar and right radial cutaneous nerve of forearm. He also had patchy loss of sensation of glove and stocking type. After that, oral and nasal mucosa were normal. In AFT was negative for skin slit smear from earlobes. Diagnosis of multibacillary Hansen disease was made clinically. Like that, we come to an end to our two clinical presentation. Now, I would like to hand over to our mentor, Dr. Reddy sir, for further detailed discussion of these cases and about lepromatous leprosy. Over to you, sir.
Thank you, Abhijit. And this leprosy is the very, very oldest days for the oldest disease known for the last many, many centuries. Even during Vedic times, it was mentioned in Sushruta Samhita. It was popular. It was known as in those days as Kushtaroga, right? And Mycobacterium leprae is the causative agent of leprosy. It was discovered by Norway scientist Dr. Hansen in 1873. That's why it is popularly known as Hansen's bacillus. This leprosy, as he already presented two cases, clinical cases. Leprosy, it is a chronic granulomatous disease. It primarily involves cooler areas of our body like skin, peripheral nerves, upper respiratory tract, eyes, testes, etc. Usually it involves cooler parts of the body, but it can infect any tissue, any organ, and can cause deformities in our body. For leprosy, the incubation period is very long, average 5 to 7 years. It may vary between 2 to 40 years, right? It may be due to a very long generation time. I hope all of you know generation time is the time required for a bacterium to multiply and to give rise to two daughter cells. And this generation time in Mycobacterium leprae is 12 to 15 days, nearly half a month. Whereas in Mycobacterium tuberculosis, 14 to 15 hours, half a day, more than half a day. Whereas in other medically important bacteria like gram-negative bacilli or gram-positive cocci, it is roughly around 15 to 20 minutes. That's why these gram-negative bacilli, they grow by overnight incubation in the laboratory, whereas tuberculosis requires 4 to 6 weeks or 4 to 8 weeks, roughly around 2 months. Whereas for leprae, we could not find a bacteriological medium to cultivate it till now because of this long generation time. And it is because of this long generation time, the incubation period is also very long in humans. Leprosy, it is classified into different types based on clinical features, bacteriological or immunological or histological features of the patients. When leprosy is classified into different types, when we say this type of a particular type of disease is not permanent, it varies within a single patient according to the chemotherapy treatment and alterations in the host immunity. Under any classification system, leprosy, it is a bipolar disease. Under any classification scheme, the leprosy is a bipolar disease. Lepromatous and tuberculosis types, they are the two extreme poles of the disease. Is it visible on the full screen, Abhijit?
No, sir.
No,
I
sir.
think that you need to first share. Your slides are not changing. Now it's going on.
Sorry for the inconvenience.
Is it visible full screen?
Yes, sir. Now
Yes,
it's
Yes,
sir.
sir.
visible, sir.
It's visible.
Okay, right, fine. So as we said, leprosy mainly involves the cooler areas of the body, like skin, peripheral nerves, and upper respiratory tract, eyes and testes. So as we said, leprosy is a chronic granulomatous disease, mainly seen exclusively human disease, mainly involves the cooler areas of our body like skin, peripheral nerves, and upper respiratory tract, etc., etc. But of course, it can infect any organ, any tissue of our body. As we just now said, the incubation period is very long, maybe due to a longer generation time in this organism. And leprosy can be classified into different types based on different features. And when we say different types, any particular type of disease in any one single patient is not permanent. It may change. The type of the disease in a single patient may change, may vary depending upon the treatment and also alterations in the immunity, right? And when leprosy is classified into different types under any classification system, leprosy is a bipolar disease. On one pole, lepromatous leprosy, and another pole, tuberculosis types will be present. They represent two extreme poles of the disease. In 1953, MedVIDz classified leprosy into four types. If you see here, lepromatous and tuberculosis, two extreme poles of the disease. Similarly, Ridley Joplin in 1966, he classified leprosy into five types. Lepromatous leprosy on another, on one side, and bottom you can see tuberculosis leprosy. In between center, you've got borderline leprosy. Between lepromatous leprosy and borderline leprosy, you've got borderline lepromatous leprosy. Similarly, between tuberculosis leprosy and borderline leprosy, we have got borderline tuberculosis leprosy. So this is the five types. He introduced a scale. Then Indian classification in 1981, it divides into five types: lepromatous type, borderline leprosy, indeterminate, pure neuritic type. This is the next one, and tuberculosis type. Ridley Joplin, they have introduced a scale for classifying this spectrum of leprosy into five groups, as we said in the previous slide. One side tuberculoid, another side lepromatous. In the center, borderline leprosy, and between tuberculoid and borderline tuberculoid, and between borderline borderline lepromatous leprosy. Clinically, leprosy is classified into two categories: passive bacillary and multibacillary. Passive bacillary, usually there may be 1 to 5 skin lesions, slit skin smear negative for leprobacilli, whereas multibacillary, more than 5 skin lesions, slit skin smear is positive for leprobacilli. Right? Passive bacillary tuberculoid leprosy, whereas multibacillary lepromatous leprosy. This is introduced by WHO. It is usually used for the leprosy control program for the treatment of patients. Now we will see some important features of lepromatous leprosy and tuberculoid leprosy. Lepromatous leprosy, it is multibacillary. Large number of leprobacilli, they are found in large clumps known as globi. They are found intracellularly inside the macrophages, which we call them as lepra cells or virchow cells. Whereas tuberculoid leprosy is passive bacillary. Bacilli are very scanty, very less in number in the lesions. In lepromatous leprosy, the skin lesions, there are many, and they are symmetrical with irregular margins, and they appear as multiple nodules known as lepromata. Plaques and xanthoma-like papules may be present. A leonine facies appearance, loss of eyebrow or eyelashes may occur lately. Whereas in tuberculoid leprosy, skin lesions are very few, asymmetrical with a sharp margin. The margin is very sharply demarcated. Lesions are usually hypopigmented, annular, usually anesthetic with elevated burdens. In case of lepromatous leprosy, neural involvement will be very late, whereas in tuberculoid leprosy, nerve involvement occurs early and anesthetic skin lesions produced very early. Nerves are enlarged and thickened. Nerve abscess may be seen, and this nerve damage is so pronounced that it may lead to certain deformities, particularly in the hands and feet. And most commonly, ulnar nerve is involved, followed by post-auricular nerve. In lepromatous leprosy, the cell-mediated immunity is very low, impaired, whereas in tuberculoid leprosy, cell-mediated immunity is adequate, normal. And since cell-mediated immunity is low in lepromatous leprosy, lepromin test is negative, whereas in tuberculoid leprosy, since cell-mediated immunity is normal, adequate, lepromin test is positive, and that's why lymphocyte transformation test is also positive, whereas in lepromatous leprosy, lymphocyte transformation test is negative because AMA is low. Similarly, CD4, CD8 T cell ratio in tuberculoid leprosy is normal 2:1, whereas here in lepromatous leprosy, it is reversed. In lepromatous leprosy, humoral immune response, antibody-mediated immune response is exaggerated. Autoantibodies are present, and it may give biological false positive reaction in VDRL test for syphilis. Whereas in tuberculoid leprosy, humoral immune response is normal, autoantibodies are not present, and VDRL test, there is no biological false positive reaction in the VDRL test. In lepromatous leprosy, prognosis is poor, right? Whereas in tuberculoid leprosy, prognosis is very good. In lepromatous leprosy, macrophages, which harbor leprobacilli, they are phoebe type, lipid laden. Whereas in tuberculoid leprosy, they are epithelioid type. This is a leonine face appearance in lepromatous leprosy. Leonine face appearance with loss of eyebrows, eyelashes. This is the deformity seen in untreated leprosy cases. Whereas in tuberculoid leprosy, you can see sharply demarcated circular lesions. Here, deformities are so damage. The deformities are very prominently seen in the hands and feet. Now, other categories of leprosy, apart from lepromatous and tuberculoid, there is borderline leprosy, also called as dimorphous leprosy, because it possesses the characteristics of both lepromatous as well as tuberculoid leprosy. And it can change, it can shift to any one particular type depending upon the chemotherapy and also alterations in the resistance, immunity. There is another leprosy, indeterminate leprosy. It is an early unstable reaction. There may be some hypopigmented macules and sensory loss may be there, but bacteriologically it is negative. So it is not clear cut whether it is leprosy or not. Early unstable reaction. This is indeterminate leprosy. There is a pure neuritic type where patients develop nerve involvement without any skin lesion. Again, here cases are mediated immunity and cell-mediated immunity, right? And in antibody-mediated immunity, antibodies are produced against various antigens of leprobacilli, but leprobacillus is an intracellular pathogen. Therefore, antibodies do not have any role in the protection against disease. That's why in intracellular infections, you know that cell-mediated immunity plays a very important role, right? So the type of the leprosy depends upon the seated immunity status of the patient. Any person with a low cell-mediated immunity usually develop lepromatous leprosy. And here CD4, CD8 cell ratio is reversed 1:2. CD8 T cells predominate. They are more in number and they are also present in skin granulomas. In the immune response, Th2 response is very predominant, which release various cytokines like IL-4, IL-5, IL-6, IL-10, interleukins. They cause exaggerated antibody-mediated immune response. As a result, many B cells will be activated, that is polyclonal B cell activation. As a result, high level of antibodies are produced, and many of them may be autoantibodies. And some of them, they give biological false positive reaction in the VDRL test. Whereas people, those who have a very good cell-mediated immunity, adequate cell-mediated immunity, they progress towards tuberculoid leprosy, right? They exhibit a delayed hypersensitivity towards lepra antigen, and here lepramin test, intradermal test is positive. And in this, Th1 response is predominant, and they release Th1 cells release particular cytokines like interleukin-2, gamma interferon, and they in turn activate macrophages. And these activated macrophages, they phagocytose and kill the leprobacilli. Here, CD4, CD8 ratio is normal, right? CD4 tells T lymphocytes, they are predominantly found in the circulation and also in the skin granulomas. The complications in leprosy is of two types. One is deformities, another one is allergic reaction, also known as lepra reaction. Around 25% of untreated patients may develop deformities due to nerve injury, that leading to muscle weakness or paralysis, or due to disease process, or due to infection or injury. The commonest deformities are, already we have seen the picture, leonine faces, sagging face, loss of eyebrow or eyelashes, saddle nose, and corneal ulcers. Claw hand, wrist drop may be seen in the hands. Foot drop, clawing of toes, inversion of foot, and ulcers in the plantar region, etc., seen in the foot. In the course of disease, leprosy, there may be many inflammatory reactions that may lead to give rise to allergy. We call them as lepra reactions. There are two types: lepra reaction type 1 and lepra reaction type 2. Type 1 reaction, the immunological basis is delayed hypersensitivity type 4. Whereas type 2 reaction, immunological basis is type 3 immune complex disease. Type 1 reaction is commonly seen with borderline leprosy, whereas type 2 reaction is commonly seen in lepromatous leprosy. Type 1 reaction manifests as an inflammation of previous lesions or new skin lesions and neuritis. Whereas type 2 reaction, in type 2 reaction, many crops of painful erythematous papules may be formed. They may become later nodular, and that's why type 2 reaction is also called as erythema nodosum leprosum, ENL. This type 1 reaction progresses towards downgrading reaction when it progresses towards lepromatous leprosy. If it occurs before treatment, if it is before treatment, it progresses towards lepromatous leprosy, we call it as downgrading reaction. If it occurs after treatment, it progresses towards lepromatous leprosy, we call it as reversal reaction. Whereas type 2 reaction usually occurs following the beginning of chemotherapy. In type 1 reaction, just in the previous slides we said Th1 predominates, whereas type 2 Th2 predominates. In type 1 reaction, other organs are not affected, whereas in type 2, allergic reaction may involve eyes, testes, kidneys, etc. The treatment for this reaction, type 1, is glucocorticoids, whereas type 2, glucocorticoids along with thalidomide, clofazimine, and other antipyretics. There is some of genetic predisposition towards leprosy is found between some tissue types. Histocompatible Q1, HLA, MT1, they've got a highly predisposition towards lepromatous leprosy, whereas HLA DR2, they've got a very good association with tubercular leprosy. So these tissue types, they've got some predisposition towards that particular leprosy. Leprosy, it is an exclusively human disease. The source of infection is a multibacillary case where abundant bacilli are present in the nasal secretions. We acquire infection by inhalation of aerosols, because large number of bacilli are shed in the nasal secretions. Sometimes the disease may result due to direct contact from person to person. People have got some stigma that leprosy is highly communicable, but leprosy is not highly communicable. It is very least infectious. To get leprosy, a very intimate and prolonged contact is necessary for a long time. Only 5% of spouses living with disease. Then there is a lepromin test in terms of tuberculosis, whereas this lepromin test here in leprosy, it cannot be used for the diagnosis of leprosy. It is not for the diagnosis of leprosy. It is for detecting cell-mediated immunity or delayed hypersensitivity, right? It is an intradermal test to detect delayed hypersensitivity reaction and cell-mediated immunity against lepra antigen. Lepramin antigen prepared from armadillo animal, nowadays widely used. Previously, Dharmendra's crude antigen was used. When lepramin antigen is injected intradermally on the inner forearm, and then readings are taken at two times. One is after 48 hours, 2 days, another one is after 21 days. Because we are taking two times readings because response to this this lepramin injection intradermal test is typically biphasic. It consists two events. One is early reaction or Fernandez reaction. Here, within 1 to 2 days, an induration surrounded by erythema appears, and it may remain for 3 to 5 days. And this early reaction correlates with the tuberculin test and indicates delayed hypersensitivity reaction. When there is an erythema more than 10 millimeter in diameter, it is considered as positive. It indicates the person had previous exposure to leprobacilli, but it does not indicate active infection. Whereas late reaction, Mitsuda reaction, usually it is taken after 21 days, 3 weeks. Positive reaction is indicated by a nodule formation more than 5 millimeter in diameter at the site of injection, and later on it gets ulcerated, breaks open. This late reaction of Mitsuda, it appears within 1 to 2 weeks, reaches peak in 4 weeks, and gradually subsides in next few weeks. Late reaction is produced against the bacillary component of the lepra antigen and indicates that the patient's cell-mate immunity is intact. So it is used for the detection of cell-mate immunity. When lepramin test late reaction is positive, it is an indication that the patient has a good cell-mediated immunity. Here you can see, in case of a positive reaction, you have got erythema and induration. In case of a negative reaction, there is no erythema and induration. Right? With two different types of antigen. So just now I told you lepramin test is not used for the diagnosis of leprosy. And late reaction of Mitsuda, it is used to measure the immune status, that is cell-mediated immunity of the person. So therefore, lepramin test is positive only when the person has got a good and adequate cell-mediated immunity. And that's how lepramin test is used to classify the leprosy patients, because tuberculosis patients have got good CMI, lepramin test is positive, whereas lepromatous leprosy, it is negative. Similarly, lepramin test can be used to assess the prognosis, right? A positive lepramin test indicates good prognosis, whereas negative lepramin test indicates bad prognosis. Similarly, to assess the resistance to leprosy in leprosy patients, we can use this lepramin test. Lepramin negative persons in whom lepramin test is negative, they have got a high risk of developing leprosy, right? Therefore, lepramin positive persons should be employed in leprosuria. Next, laboratory diagnosis. Total 6 samples will be collected, 4 samples from the skin, usually from forehead, cheek, chin, and buttock, 1 from earlobe, 1 from nasal mucosa by nasal scraping or nasal blow. Usually, slit skin smear is the technique that we use to collect skin sample from the earlobes. Here, the edge of the lesion should be preferred. The lesion should be first cleaned, disinfected with spirit, and it should be pinched up very tight to minimize bleeding. A 5 millimeter length incision cut should be made with a scalpel, slightly deep enough where you can get into inside layers. After making incision, the blood that exudes should be wiped off, and then the scalpel blade should be rotated transversely. You are making a longitudinal incision, and then you have to rotate the blade transversely to scrape the sides and base of that incision so that you will be able to get a tissue pulp from below the epidermis. And this tissue pulp can be smeared uniformly over an area of 8 millimeter diameter on a slide, that is slit skin smear. We can also take nasal scrapings. A very blunt, narrow scalpel blade can be introduced into the nose where you can scrape internal septum to remove, to obtain a piece of mucous membrane. Then that can be placed on the glass slide and you can tease into smear. Nasal blow, particularly early morning mucous material can be collected by blowing the patient's nose on a clean cellophane sheet, right? And apart from that, biopsy tissues can be taken from thickened nerves or nodular regions for histopathological examination. After collecting samples, the most important diagnostic method is direct microscopic examination to demonstrate acid-fast bacilli in lesions. The smears are stained by Zedden staining. Here we use 5% sulfuric acid for decolorization, whereas in tubercle bacilli, we use 20% sulfuric acid because leprae bacilli are less acid-fast than tubercle bacilli. After staining, when we examine under the oil immersion lens, we can notice pink-colored acid-fast bacilli against a bluish background. The bacilli, leprae bacilli, are usually straight or slightly curved. They are present singly or in groups like cigar-like bundles. And in the groups, these bacilli, they are bound together by a lipid-like substance called as glia. And these groups are clumps, cigar-like bundles. We often call them as globi. And they are present intracellularly inside the macrophages. And these macrophages, which contain these globi, we call them as virtuous lepra cells or foamy cells. You can see here, they are present in cigar-shaped bundles inside the macrophages. Here also you can see many pink-colored bacilli present in cigar-shaped bundles inside the macrophages against a bluish background. The live bacilli which are living, they take very uniform staining. Entire bacillus stains uniformly same color, whereas bacilli which are dead bacilli, they show a fragmented or broken or granular appearance. The smears can be graded based on the number of bacilli seen in one oil immersion field. For example, if you see, or per oil immersion field, if you see 1 to 10 bacilli in 100 oil immersion fields, you can score it 1 plus. If you see 1 to 10 bacilli in 10 oil immersion fields, you can give a score of 2 plus. If you see 1 to 10 bacilli per every oil immersion field, in one oil immersion field, 3 plus score can be given. If you see 10 to 100 bacilli per oil immersion field, 4 plus score, 4 pluses can be given. If you find 100 to 1000 bacilli per oil immersion field, 5 pluses can be given. If more than 1000 bacilli or bacilli in clumps and globi in each oil immersion field, 6 plus you can give. So as the number of pluses increases, the number of bacilli are more infection is severe. There are 2 indexes, bacteriological index and morphological index. This bacteriological index, it is based on the total number of bacilli, live or dead, both, it counts both, seen per oil immersion field, right? Total number of bacilli, living or dead, seen per oil immersion field. And this bacteriological index is calculated by totaling the number of pluses that are scored in all the smears divided by the number of smears examined. Total number of pluses scored in all smears divided by the number of smears. For example, if you have examined 8 smears and if you have got total 16 pluses, 16 by 8, so that bacteriological index will be 2. To calculate this bacteriological index, minimum 4 skin lesions, 1 nasal swab, and both earlobes have to be examined. Morphological index is more meaningful than bacteriological index because the morphological index counts only the percentage of uniformly stained bacilli, that is living bacilli. So therefore, it is a better marker to monitor the treatment response prognosis. When a patient clinically improves, the morphological index should decrease, whereas pathological index remains the same. Morphological index is calculated by dividing uniformly stained bacilli divided by total number of bacilli multiplied by 100 percentage. Then for leprobacilli, till today we could not find a bacteriological medium like blood agar or chocolate agar or LJ medium for tubercle bacilli. Such medium we could not find. Mouse foot pads were used. Mouse foot pads were used for the propagation of these viruses by injecting the sample into the foot pads. But this method is not suitable for routine diagnosis. It is mainly useful for drug sensitivity testing and for research purposes. And nine-banded armadillo. Leprosy is exclusively human disease, and now we found that nine-banded armadillo also equally susceptible to leprobacillus infection. So just now I was telling you mouse foot pad inoculation. It was discovered by Shepherd. The Mycobacterium leprae, or the sample, can be inoculated into the foot pads of mice and kept at low temperature, 20 degrees centigrade, for 6 to 9 months, right? And after injecting intradermal into the foot pads of the mice, usually within 1 to 6 months, a granuloma will be developing. And this mouse foot pad inoculation has got certain advantages. It is 10 times more sensitive than direct microscopy, and it is useful in detecting drug resistance. It is also useful in evaluating the potency of the antibiotic or drug. It detects the viability of the cell in the sample, whether the living bacilli are present or not. The disadvantage is it is time consuming. By the time granuloma develops, at least 6 months or sometimes 9 months it may take. And there are certain ethical issues regarding the use of animals in the laboratory. This is how a granuloma develops when we inject leprobacilli or the clinical specimen into the foot pads of mice. Then there is another mice called as nude mice. Nude mice is one in which cell-mediated immunity is completely suppressed. Completely cell-mediated immunity is deficient. Either it may be due to thymectomy, removal of thymus gland, or by injecting anti-lymphocyte serum, antibody to lymphocytes, right? Due to this, the T lymphocytes are inactivated, so that cell-mediated immunity is completely suppressed. If you see here, the normal white mouse is the normal mice, whereas this one is the nude mice in which cell-mediated immunity is deficient due to thymectomy or due to the administration of anti-lymphocyte serum. And just now I told you, nine-banded armadillo is highly susceptible to infection, just like humans, right? A generalized infection is produced in the armadillos, nowadays widely used in the experimentation. Of course, leprosy is exclusively human disease, and natural disease is also found the ancestors of humans, chimpanzees, and monkeys in the West Africa. This is the nine-banded armadillo animal. Antibody detection is not widely used in the diagnosis of leprosy. Usually, ELISA test can be used to detect antibodies to PGL1 antigen, phenolic glycolipid 1 antigen of leprobacillus. It is useful. The test is positive in 95% of untreated lepromatous cases. And with the effective treatment, or if a good response is there for the treatment, the titer will be decreasing, right? So it is very useful in lepromatous leprosy, but again, its sensitivity is very low in tuberculoid leprosy. And nowadays, fluorescent leprosy antibody absorption test is used to identify asymptomatic cases, subclinical cases, by detecting antibodies. Then, in the diagnosis of leprosy, a differential diagnosis also very much essential. There are many other conditions which clinically resemble leprosy. For example, birthmark, tinea versicolor, and tinea corporis, pityriasis alba, lichen planus, drug eruptions, psoriasis, dermal leishmanoid, lupus vulgaris, Kaposi sarcoma, sarcoidosis. All these conditions may sometimes clinically confuse with the diagnosis of leprosy. The next, treatment. Until 1982, dapsone was the only one drug used for the treatment. And because of the continuous use of dapsone, the bacilli have developed drug resistance. Nowadays, even multi-drug resistance also has become a very big problem in the leprobacilli. That's why nowadays we are using multi-drug therapy in the treatment of leprosy as in tuberculosis. The most recommended drugs are dapsone, rifampicin, clofazimine, and alternate drugs are egenamide, quinolones, minocycline, and clarithromycin, etc. WHO recommended a multi-drug therapy regimen, which is slightly modified in the 2018. According to this, dapsone is given 100 mg daily, rifampicin 600 mg once a month, clofazimine 300 mg once a month, followed by 50 mg daily. And the duration of treatment will be 6 months for passibacillary leprosy and 12 months for multibacillary leprosy. And the follow-up is annually for 2 years for passibacillary and 5 years for multibacillary. That's why I told you in the beginning, the classification of passibacillary and multibacillary is usually used in the control of leprosy, in the eradication of leprosy, for the treatment of leprosy cases. For prevention, active case finding and effective treatment of the cases is very important. Case detection and treatment of the cases, that is the most important. There is no effective vaccine, and chemoprophylaxis, household contacts may be treated with dapsone. There are many vaccines under trial, but till today no vaccine has been approved. No effective vaccine is available. Thank you very much. I hand over to the Abhijit.
Thank you, sir. Thank you, sir, for your valuable time and guidance in conducting this webinar. I would like to, I hope today's webinar would have helped the participants of this webinar in better understanding this disease, its pathogenesis, and the ways to treat and prevent this disease. I would like to apologize for the delay in the beginning of this webinar. There were some technical difficulties in the beginning. So thank you all for bearing up with us. Before concluding, I would like to bring the attention of all the participants on our upcoming event, which is a quiz being organized by the by Games Nepal in association with Maro, which is a quiz on genitourinary system. The slide I'm showing it right now. So I would urge all the participants of this today's webinar to register for the quiz and participate in this. I hope this was a very knowledgeable experience for all of us. Thank you, sir.
Welcome.
So with this, I would like to end this meeting.